But I would also advocate looking at other sort of topical anti-inflammatories like calcipotriol, right? A vitamin D analog. So, a sort of treatment regimen that I can kind of see right now, and I'm just kind of speaking off of script, would be something like, let's say, oral pioglitazone 15 milligrams a day, followed by clobetasol propionate 0.5%, used somewhat frequently, maybe for 2 week cycles, 2 weeks on, and then after that, not using that for like a month. And then using calcipotriol. Calcipotriol, I think it's at 0.005% concentration, using that somewhat daily, topically, right? And maybe for, just to see how things are, possibly a topical metformin, right? And the idea is to kind of target the inflammation as hard and as fast as you can and still, over time gradually dropping those topical treatments, right? Not using the clobetasol propionate solution every day. And then after a time, reducing the amount you use the calcipotriol, this topical vitamin D analog, which, as a side note, is used in conditions like psoriasis, right? It's used in psoriasis to kind of slow down the inflammation and get rid of those plaques as well. But it's also used in conditions like alopecia areata. So it's noted in its anti-inflammatory effects on the tissue. But at the same time, we also want to address the dysfunction here, which is the PPAR-GAMMA receptor being downregulated. So by using pioglitazone, you use it as an agonist, right? It sort of increases the activity of the PPAR-GAMMA receptor. So now you're actually regulating the lipid metabolism in the tissue properly, right? And you'd be taking this thing orally, but if you can possibly get it as a topical solution, maybe that could help mitigate side effects down the line if you ever are to experience them, right? So I think my estimation for a topical pioglitazone sort of solution would be between 2 to 5%. That's just my estimation. But also at the same time, a retinoid receptor agonist would possibly do well, right? So something like tretinoin, topical tretinoin, because you could have a weird case where maybe your retinoid receptors are downregulated and not working properly. And as I mentioned earlier, right, the PPAR gamma receptor has to combine with the retinoid receptor or retinoid alpha receptor. So these two things have to come together in order to actively activate certain genes in your DNA that's responsible for metabolizing lipids. And it does this by going into the sebocytes and various other sort of cells in the hair follicle and skin structure in order to get rid of those lipids, right? But mostly from what I've seen in the literature, the scarring alopecia deals with a dysfunction of the PPAR gamma receptor. So just to put this in plain English, pioglitazone, oral pioglitazone that is, 15 milligrams. From there, clobetasol propionate, and then the calcipotriol 0.005%, something like that. But again, go talk to a doctor. I'm not a doctor. I can't, prescribe these things, but I certainly can talk about the literature. So that's kind of like the treatment intervention that I can see addressing if somebody is to have their dupa or retrograde alopecia sort of diagnosed with a biopsy, and if that biopsy comes back as lichen planopilaris or some other condition, now you can effectively know how you would go about potentially treating it.